and I just wanted to introduce you to our second speaker for today. So here we have Dr. Hannah Wardle. She is an early career researcher with a vision to eradicate the physical, psychosocial, and economic burden associated with cancer and its treatment. To date, her research has been critical in understanding how the bacteria in our gut contribute to certain side effects of the chemotherapy, and she has published more than 50 research papers in this area. She is also forging a strong international profile and continues to increase her leadership capacity in this area. At the moment, she is the vice chair of the mucositis study group, and she hopes to use this opportunity to improve collaboration between different study groups and multidisciplinary members. A little bit more background history. So Hannah was under a fellowship and was in the Netherlands, where she led a program of research that aimed to develop and test new strategies to better support models in conducting both clinical and industry-supported research projects. And since she has come back to Australia, she's also established her own one called the Supportive Oncology Research Group. And their aim is to have strong foundations with consumer engagement, collaboration, and to make an impact. And they have secured more than 3 million in competitive research funding and currently have a 1.5 million funding to support a new clinical trial to investigate if medical cannabis improves well-being in people with advanced cancer. She also has a great partnership with the biome Bank, which is Australia's largest stool bank, and is working to establish a fecal transplantation service for people who have had a stem cell transplant. She is passionate, and she is also a very good advocate. And she has been recognised as one of South Australians 40 under 40s in 2020. And she's also the 2021 South Australian Tall Poppy Recipient of the Year. So without further ado, let me introduce you to Dr. Hannah, and she can give us our second talk.
Thank you very much for that introduction. I always feel a little bit awkward with that introduction because it makes me feel a little fancier than I really am. But I think hopefully through that, what came through is that I am a strong advocate for improving the quality of life of people undergoing cancer therapy. And I have a very strong interest in people with blood cancer, in particular myeloma. I work heavily with the Myeloma Research Laboratory here in South Australia because we know people with myeloma seem to do it particularly tough with some of the physical and psychosocial consequences of their treatment. So for today, we're going to be talking about a topic that is absolutely dear to my heart, and that is the gut microbiome, which is really all the bacteria in people's guts. It also includes other microorganisms, but bacteria certainly dominate our intestinal tract. And a lot of my work is understanding the changes in these bacteria and the broader gastrointestinal environment in myeloma and other cancers, and looking for ways in which we can better support gut health throughout treatment. So as I mentioned, my name is Hannah and I'm a laboratory scientist by training. And so what I really want you to remember throughout today's presentation is that I'm not a clinician. I'm here aiming to provide new insights into the mechanisms of some of these consequences of treatment and hopefully develop some new solutions that with collaboration with our clinical partners, we can get into clinical trial and into clinical practice. So in today's presentation, what I will be covering is firstly, I really want to emphasize that supportive oncology is really an integral part of modern cancer medicine. I know you've had some presentations over the last few sessions or webinars that have focused on symptom management and quality of life. And I think it's really fabulous to see that because that's not always the case. I then will discuss how myeloma drugs negatively impact gut health before moving on to approaches in which we can support gut health in myeloma. Some of these, or most of these, are very much in the experimental and development stage. And finally, of course, because we know that many people with myeloma, particularly people that have received stem cell transplantation, are largely immunocompromised, I will discuss briefly some of the safety considerations for bacterial interventions in myeloma. Okay, so supportive oncology, what is it and really why should we care? Well, what we know is that cancer survival is really increasing quite rapidly, and this is reflecting some of these incredibly sophisticated new therapies like the CAR T-cell therapy we've just heard about, And we now know that the 5-year survival rates for all cancers is above 70%, and for myeloma, it's above 50%. And so what this means is that we are really faced with a large and growing population of people who are living with or beyond a cancer diagnosis. Now, what we know is that when people are living with or beyond a cancer diagnosis, this doesn't necessarily mean that everything is hunky-dory. We know that a lot of people will experience an unwanted symptom or side effect as a result of their treatment or their disease. And this unfortunately persists chronically in about 30 to 40% of the time. And so I think it really comes back to this concept of not dying does not always mean living. I really want to emphasize that with a cancer diagnosis, there are a range of symptoms and side effects that will persist. And this really does impact on the individual's ability to live a healthy, happy, and fulfilling life. And in the context of myeloma, or well, more broadly, I should say, supportive oncology really is this umbrella term used to describe the strategies, whether they be pharmacological or non-pharmacological, to prevent and manage these adverse events. Now, as I mentioned, gastrointestinal health or gut health is one of my particular areas of interest. I did my fundamental training in gastrointestinal physiology and immunology. And so I'm really interested in understanding how the drugs we use to treat myeloma impact gut health. Now, we know that nausea and vomiting is a pretty common symptom. However, increasingly, whilst we consider it to be a gastrointestinal symptom, I suppose, we now know that most of the mechanisms that drive nausea and vomiting tend to come from changes in the brain. However, we also know that some of the drugs used to treat myeloma cause bloating and abdominal pain. They can cause diarrhea, and they can also cause constipation. And this tends to be a bit of a silent one. People don't really notice that it's a problem until it becomes a big problem. And so constipation is quite a strong interest of mine. Now, in terms of the sort of trajectory of these symptoms, we tend to see that nausea and vomiting are usually short-lived after chemotherapy and on the whole are relatively well managed. That's not to say they aren't a problem in some people, but typically these symptoms are across the board relatively well managed. Diarrhea is more common after bone marrow transplantation because of the intensity of chemotherapy that is used, but it's also seen in lenalidomide therapy. So when people are receiving lenalidomide as a maintenance therapy, we tend to see quite a lot of diarrhea. And constipation and bloating tend to be more common with Velcade or bortezomib, and I'll explain the mechanisms of this in a little while. So how do these drugs cause these symptoms? Well, in terms of chemotherapy, we know that most chemotherapeutic drugs work by targeting rapidly dividing cells. So cells that are consistently replicating and replacing themselves. And this is a very common or core trait of many cancerous cells, but it unfortunately is a very common feature of many healthy cells. And so the gastrointestinal tract is one of the most rapidly dividing cell populations in the body. We see a total replacement of the lining of the gut in about 24 hours. And so because of this inability of chemotherapy to differentiate between these cells, we see a lot of cell death in healthy cells that are rapidly dividing. So just like those ones throughout the gut. So what we can do is we can look at the microscopic structure or architecture of the intestine. So on the left-hand side here, there's an image of a cross-section of the intestine. And one of the most important features of the intestine is these really long finger-like projections. These are called villi. And after chemotherapy, this is after a drug called melphalan, which is commonly used in stem cell transplantation, we can see that these long finger-like projections become very blunt and the general architecture of the intestine becomes very different. And so not only do we lose these finger-like projections, but we also lose the crypt structure at the bottom, that's sort of the pit structure at the bottom of these finger-like projections. And this is because these cells have been killed and they're simply not able to repopulate the intestinal lining. Now, we're actually able to measure this quantitatively. So using a blood test, we can measure levels of plasma citrulline in the blood of people undergoing high-dose melphalan treatment. And we can see that we get this really very predictable decrease in citrulline that tends to begin recovering from around day 15 to 20 after stem cell transplantation. And this is a really important thing because in those slides I just showed you, they were actually collected from an animal model of chemotherapy-induced gut injury. But of course, in people, it's very difficult to get biopsies and samples of the gut. So this has been a really important way in which we can monitor people's gut injury in a relatively non-invasive manner. Now, when we think about the impact of this gut injury on people, we know that the average adult gut is around 30 meters squared, maybe a tennis court or two, depending on the person. And it's this large surface area that is absolutely critical for all of those important functions of the gastrointestinal tract. So the absorption of nutrients, the absorption of water. It's also a really important barrier structure because, of course, everything we put in our mouth is relatively dirty. It might have toxins or other pathogens in it. And so the barrier properties of the gut are really important as well. And so when we have this damage in the lining of the gut, we see a 50% reduction in the surface area of the gastrointestinal tract. And so understandably, we can appreciate that we have lower nutrient absorption, we have lower water absorption, and we have reduced barrier function. Now, symptomatically, I should say, this is why we see malnutrition being quite common in people undergoing chemotherapy. We see diarrhea, and we also see things like infection. And this is because we have bacteria moving from the inside of the gut across this damaged barrier and into the blood. However, what we're increasingly recognizing for some of these myeloma drugs is that there are many more mechanisms beyond this sort of indiscriminate damage to rapidly dividing cells. And this is particularly the case for some of the other drugs that are commonly used in the context of myeloma, like bortezomib or Velcade. And this drug is somewhat different, I suppose, to chemotherapy drugs because it doesn't necessarily work by damaging rapidly dividing cells. It works by inhibiting proteasomes. And what we know is that nerves, so these are the cells within the body that create the action potentials that allow different body systems to move and operate. These nerves are very susceptible to damage by bortezomib. Now, in the gastrointestinal tract, these nerves are what push food from our mouth through our esophagus, through our intestines, and hopefully, eventually, out the other end. And so what we're able to show using some models of bortezomib is that we see that food simply is not moving down the gastrointestinal tract. And we're able to measure this by measuring the stomach weights of mice that have been treated with the drug bortezomib. And so essentially what we're seeing here is I guess almost a paralysis of the gastrointestinal tract. And this is the mechanism by which we believe constipation is being caused by some of these drugs. Now, when we think about the gut microbiome, these bacteria in the gut, what we know is that the human gut is home to trillions of bacteria. And in the adult gut, it's around 2 kilos that are found within the large colon or the large bowel. I mean, 2 kilos is a huge amount of bacteria. And in fact, it's now considered that if you compare the amount of bacterial genes or DNA compared to human DNA, there's actually more bacterial DNA on the human body than there are human DNA. And so in many ways, we are more bug than human. And so it shouldn't be surprising that these bacteria are absolutely critical to our health, and they support a healthy immune system, they support brain function and metabolic activity, so hormone production. In particular, the hormone serotonin, which is our feel-good hormone. This is directly produced by interactions between bacteria and the cells lining our gut. And In fact, if you take an animal and you completely eradicate all bacteria from that animal, it's completely unable to survive unless it's kept within a really confined environment where there are no exposures to any pathogens or anything dangerous, because they simply do not have any strong or robust immune responses to be able to deal with these challenges. Now, what we know about the bacteria that live in our gut is that they tend to rely on two very important things. They seem to be working. There we go. Is a warm and comfortable home. And in this context, that is the intestinal lining. And the second thing that they rely on are regular meals, just like us. And this is typically provided to these bacteria by the fiber that we, the host, ingest. And so if you think about those two mechanisms that I described over the last few slides, we can appreciate that myeloma drugs impair both of these things. So they damage the lining of the gut, destroying the home that the bacteria really very much rely on to survive. And the food that we ingest is simply not making its way down to the gut to support these bacteria. And so essentially what we start to see in the microbiome of people undergoing treatment for myeloma is that it moves from being this beautiful, diverse, lush ecosystem of bacteria into something that looks quite damaged, quite depleted, and generally much less diverse. I mean, this is an extreme example here, this desert. It's absolutely not as obliterated as this suggests, but I guess you could maybe compare it to a slightly less intense rainforest. And so we're able to measure this, and this is called microbial diversity. We're able to take fecal samples from people undergoing myeloma. This is some data from people undergoing stem cell transplantation for myeloma. And we're able to look at the number and the relative balance of different bacteria in these samples. And we can see that over time, so from day 0 to day 30 after transplant, there is a significant decrease in the diversity of the microbiome. This does luckily recover. This late phase shown in the red is beyond 30 days, but to be honest, most of these samples were collected around 90 days after transplant. So it does take quite a long time for the gut microbiome to recover. We're also able to look at the number and types of bacteria that inhabit people's gut. So this is again that same cohort of people, and each vertical bar represents a sample that has been taken. On the left-hand side, we've got individual samples, individual patient samples collected over this time course, and each of the colors represents a different family of bacteria. Now, what I've shown here graphically is that bacteria shown in greens and blues, they're typically the bacteria that we would consider good bacteria. And the ones shown in darker red and pinks, they're typically these bacteria that we would consider bad. These are pathogenic bacteria that tend not to be so good inside the gut. And we can see that over time, as that microbiome becomes less diverse, we get a domination of these bad bacteria. And so this is what we call dysbiosis, which is essentially a term used to describe the balance of good and bad bacteria in the gut. Now, increasingly, what we're starting to understand is that these dysbiotic changes in the gut microbiome actually predict a range of unwanted consequences. So we can appreciate immediately that they impact gut health, typically having a domination of these bad bacteria in the gut will lead to things like diarrhea and maybe some abdominal pain. But we also know that it is the biggest predictor of sepsis or bloodstream infection in people undergoing stem cell transplantation. So this image on the left-hand side here shows it's a swab of blood that we've collected, and it shows that there are E. coli present in this blood that have directly translocated, so they've moved from the lumen of the gut into the blood. And so I guess this somewhat challenges what we have thought for a very long time. It's always been considered that many of the infections we see in people who are immunocompromised come from some external environment, perhaps hospital services, infected catheters or central lines. But in fact, they're coming from the bacteria that are naturally present within our gut. But these bacteria or these bad bacteria are typically kept at very low levels. So as a result, we see an increase in the duration of hospitalization in people that have worse microbial damage after treatment. We also see increases in the nutritional requirements for these patients, so an increased need for parenteral nutrition. And increasingly, there is data to suggest that the worse and the longer the duration of dysbiotic changes in the gut microbiome, the higher the risk of disease progression and even relapse. And so as a result, I would say that there has been this really intense and enthusiastic investigation of how we can better support gut health to avoid these unwanted consequences. And when we think about how we can support the microbiome, there are a number of different ways. Firstly, there are what we call prebiotics. These are typically dietary strategies that are used to support gut bacteria by providing the energy input that they need. And secondly, there are probiotics, and these are often referred to as bugs as drugs. So this is when we directly provide the live bacteria, which are usually provided in a capsule, and these can be used to then colonize the gut. Now, in terms of probiotics, there has been a lot of hype, but not necessarily a lot of evidence. I think the last estimate I saw was that the probiotic market is something around 95 billion US dollars. It's a huge market. This has been an area that has grown very, very quickly. And certainly there is some emerging evidence, experimental evidence, to suggest that probiotics slow the progression of smoldering myeloma into active disease, and some evidence to show that they can reduce the symptom burden of treatment. However, it has been extremely challenging to draw robust conclusions because there are many different types of probiotic formulations available in the market, and each study seems to use something different. And so it has been really, really difficult to draw consistent conclusions across these studies. And while I don't have time to go into it today, I would absolutely recommend people have a look at this paper here. It does show and go through all the studies that have been conducted using microbial-based interventions, whether that be probiotics or prebiotics. But I think there's this statement or this perspective that probiotics are safe. You know, they're generally not considered a medication, they're good bacteria, so why not just take them anyway? And I think what's really important to emphasize is that this is somewhat counterintuitive, but actually probiotics can reduce the diversity of the gut microbiome. So if we think back to that rainforest image, when we give just a couple of types of bacteria, which most probiotic formulations are, you tend to dominate that microbial ecosystem or that rainforest with just one type of bacteria or one type of tree. And in fact, there has been a really important study that came out a couple of years ago that showed that probiotics given to people who have just had a course of antibiotics can actually slow the recovery of the gastrointestinal microbiome. Interestingly, this study also compared the use of fecal transplant. This is a method where we collect fecal samples, we process it, and we give it to the patient either by a colonoscopy or by an enema or by capsules. And this study was able to show that if you gave a fecal transplant after antibiotics, we saw a very rapid recovery in the microbiome. And so for this reason, fecal transplants really have become quite an area of intense interest, particularly in stem cell transplant recipients. However, the majority of evidence is absolutely focused on the allo transplant setting. And I think another really important factor to consider in this setting is that whilst there has been a lot of interest in fecal transplants and also probiotics, and certainly we've started to see these strategies used as a treatment strategy for things like graft versus host disease in the allotransplant setting, These have typically only been applied as a very, very last resort. And this is because there's a lot of fears around the risks of providing bacterial interventions in people who are immunocompromised. I mean, for a long time, we've even prevented people from eating food that may have some degree of bacterial presence on it. So it really has remained quite a controversial area. However, there is a really nice study that was, or a review, I should say, of the literature that was published recently that evaluated the safety of using probiotics in people undergoing stem cell transplant. And they were able to conclude that the evidence really does not suggest there is any additional risk of using these products in a patient who is immunocompromised. However, they did absolutely recognize that there haven't been direct comparisons. Most of the evidence has been collected retrospectively, so by looking back at studies or clinical practice. But if we think about the intestinal environment, and if we think back to that idea that actually intestinal damage or toxicity and the microbiome is predictive of infection, we can begin to actually put forward a consensus or a perspective that providing good bacteria would actually decrease the risk of infection. And so this is some data coming out of the Netherlands that actually shows the damage to the mucosal lining in the gut is a bigger predictor of infection risk compared to neutropenia. And so from this, we would suggest that actually supporting good bacteria, providing bacterial interventions in this time of severe immunosuppression may be a protective mechanism to reduce infection risk. It feels very counterintuitive, it feels risky, but scientifically it really does make sense. So I think that this is really going to be an area of intense investigation over the next little while, is how we can deliver and support the microbiome in a safe and effective way in an immunocompromised patient. Now, when we think about how we can do that, we can certainly begin to appreciate the complexities of delivering a fecal transplant to someone who may be very immunocompromised. This is certainly a challenging prospect. Not only are they immunocompromised, but they're also generally quite unwell. And so providing things like an enema or a colonoscopy, potentially even capsules, may be extremely challenging to achieve. And so something that we've been looking at is how we can indirectly support the gut microbiome by supporting the intestinal lining. The lining of the gut that I mentioned previously was damaged by chemotherapy. This damages the home of the microbiome and therefore leads to these microbial changes. And so I collaborated with some colleagues over in the Netherlands to conduct a study using the drug anakinra, which is an anti-inflammatory agent, which has been shown to be able to support the lining of the gut in other conditions similar to those seen after chemotherapy. And we were able to show that when we used anakinra, when we supported the lining of the gut, we were able to reduce the expansion or the overgrowth of some of these bad bacteria. So this little section here on the graph is very high in the chemotherapy only treated animals. However, when we compared it to that of our anakinra treated animals, there was a significant reduction in this overgrowth of bad bacteria. We then also were able to show that this reduced this very intense peak in body temperature. So this is fever, indicating that there has been an infectious event occurring. And so for us, this was really promising data to suggest that we might be able to support gut health and these gut bacteria indirectly by supporting the lining of the gut and making sure that that is not damaged as severely as it would be under normal circumstances. So I think I'm getting pretty close to the end of my presentation now. So I just wanted to emphasize that this is some really exciting research that we did conduct, and it has now actually transitioned into a phase 2 clinical trial, which is currently almost finished in the Netherlands. And we're really excited to see that hopefully this can be a new strategy to minimize the infectious and unwanted consequences of gut dysbiosis or gut damage in people undergoing stem cell transplantation for myeloma. So with that said, the take-home messages from my presentation today are that the drugs used to treat myeloma really do adversely affect gut function by damaging the lining of the gut and also the nerves that control the motility of food throughout the gut. These changes lead to disruptions in the gut microbiome, which, as I explained, can increase the risk of adverse events and worsen treatment outcomes. And we're really working very hard to actively try and design better ways to support gut health that are not only effective, but also really are truly feasible to implement. So these might be things like fecal transplant, which I am also working on at the moment, but also indirect methods like anakinra. I would like to finish up by thanking all the members of my lab and also my collaborators in the Netherlands, as well as the haematology department at the Royal Adelaide Hospital. And of course, the generous donors and funders, study participants, patient advocates, and their families. And if you're interested in connecting, please feel free to reach out if you have any questions or project ideas. We're always really happy and excited to learn from the lived experiences of people and hopefully together work to improve the outcomes for myeloma. So thank you very much.
Thank you, Hannah, for giving us such a great talk that was so interactive, so informative, and you explained the concepts of the gut biome so well. I think we do have a few questions from the live chat. The first one is, is quinoa and cacao, are they useful in improving gut biome at all?
So kefir is a form of probiotic. Yep. So this is a type of food delivered probiotic, which I didn't actually mention in my presentation today. There are very absolutely a number of foods that have probiotics, so yogurts as well, and kombucha and all of that. Again, it comes down to this fact that different studies have adopted very different strategies. So, it might be someone taking one spoonful of kefir, one spoonful of yogurt, and a kombucha drink. So there are inconsistent reports of positive and not negative, but not positive effects. So it's been a really difficult field to synthesize the evidence from. Certainly there is some supportive evidence, but across the board, the general take-home message is that if you eat a healthy diet and do not have any gut diseases, typically these interventions don't have any effect. If there are reasons why your gut environment is damaged, then these can have some effects, but it is really important that those, if you are trying any of those interventions at home, that you do mention them to your doctor, because there are examples where they can worsen treatment outcomes.
Thank you for answering that. We have another question. So for people who are on lenalidomide who have chronic diarrhea, how would that be best managed?
It's a really good question, and actually a project that I'm about to start with a colleague of mine at the Royal Adelaide Hospital, Angie Young. So we're essentially at the moment, there is very limited understanding as to why lenalidomide even causes diarrhea. And so without that insight, it's really difficult to provide some practical solutions as to how it can be best managed. And unfortunately, that's why most doctors are really only able to provide very superficial interventions. I know that there is some evidence to show that bile acid sequestrants, so these are drugs that bind up all the bile in your intestinal tract, that these have some efficacy. And this is because lenalidomide is thought to potentially damage the part of the intestine that absorbs these bile acids. And so when they're not absorbed, they reach the colon, the large intestine, and they can be very damaging to the large intestine. So I think that's probably where the best evidence is at the moment, is for bile acid sequestrants, but it seems that different doctors have different preferences on that as a therapy. So I would absolutely encourage you to talk to your doctor about bile acid sequestrants and get their perspective on it.
Thank you so much, Hannah. That's all the questions we have. And thank you again for such a great explanation and just such a great informative talk about the
Thank you
gut
very
biome.
much. Thanks.
Thank you.